Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. In this third episode, we are zooming in on tricyclic antidepressants or TCAs. By the late 1950s, psychiatry had already witnessed its first pharmacologic treatments for depression with monoamine oxidase inhibitors or MAOIs. But another discovery was about to transform antidepressant therapy for the next several decades. Unlike MAOIs, which emerged from tuberculosis treatment research, the tricyclic antidepressants were discovered during attempts to develop better antipsychotic medications. In the mid-1950s, pharmaceutical researchers were studying compounds structurally related to chlorpromazine, the first widely used antipsychotic. Scientists were hoping to create a more effective treatment for schizophrenia. One compound in particular did not perform well for psychosis, but clinicians noticed something unexpected. Patients who were withdrawn, slowed, and severely depressed began showing improvements in mood, motivation, and engagement. That compound was imipramine, introduced clinically around 1957. What had failed as an antipsychotic became the first tricyclic antidepressant. The primary antidepressant mechanism of tricyclics involves inhibition of monoamine reuptake. These medications block the transporters responsible for reabsorbing serotonin and norepinephrine back into presynaptic neurons. By preventing reuptake, tricyclic antidepressants increase the concentration of these neurotransmitters in the synaptic cleft, enhancing signaling across mood-regulating neural circuits. Tricyclics interact with multiple receptor systems. In addition to inhibiting serotonin or epinephrine reuptake, they block histamine receptors, muscarinic cholinergic receptors, and alpha-1 adrenergic receptors. This broad receptor profile explains both their therapeutic effects and their side effect burden. Imipramine became the prototype for the entire tricyclic antidepressant class. Clinically, it is usually started at relatively low doses to improve tolerability, often around 25 to 50 milligrams daily, typically given at night. The dose is then gradually increased over several weeks depending on patient response and side effects. Effective antidepressant dosing commonly falls between 75 and 200 milligrams per day, although some patients with severe depression may require doses up to approximately 300 milligrams daily. In addition to major depressive disorder, imipramine has also been used in panic disorder and historically in the treatment of nocturnal enuresis in children. One of the most widely recognized TCAs is amitriptyline, introduced in 1961. Amitriptyline strongly inhibits serotonin and norepinephrine reuptake, but also has powerful antihistamine activity. This contributes to its sedating properties, which is why it has long been used in patients with depression accompanied by insomnia or chronic pain syndromes. Treatment usually begins at 25 to 50 milligrams at night with gradual titration. Effective antidepressant dosing typically falls between 75 and 150 milligrams per day, though some patients may require doses approaching 300 milligrams daily. A related compound is nortriptyline, introduced in 1964. It is the active metabolite of amitriptyline and generally produces fewer anticholinergic side effects. Because of this improved tolerability profile, it remains one of the tricyclic antidepressants most commonly used in modern clinical practice. Treatment often begins around 25 milligrams daily and is gradually increased. Most patients achieve antidepressant benefit within a range of approximately 50 to 150 milligrams per day. One advantage of nortriptyline is that therapeutic drug monitoring can guide treatment, with plasma concentrations typically targeted between 50 and 150 nanograms per ml. Desipramine, introduced in 1964, primarily inhibits norepinephrine reuptake and tends to be more activating than sedating. Because of this pharmacologic profile, it has historically been used in patients whose depression presents with severe fatigue and psychomotor slowing. Initial dosing often begins around 25 to 50 milligrams daily with gradual titration. Therapeutic doses typically fall between 100 and 200 milligrams per day, although some patients require higher doses depending on metabolism and response. In 1967, clomipramine entered clinical practice and would later become particularly important for anxiety-related disorders. It has strong serotonin reuptake inhibition and has become one of the most effective medications for obsessive-compulsive disorder, and even today. Treatment generally begins with approximately 25 milligrams daily, followed by gradual titration over several weeks. Typical therapeutic dosing ranges from roughly 100 to 250 milligrams per day, depending on response and tolerability. Doxepin, introduced in 1969, inhibits serotonin and norepinephrine uptake, but also has extremely strong antihistamine activity. At traditional antidepressant doses, typically ranging between 75 and 300 milligrams per day, doxepin functions as a conventional tricyclic antidepressant. However, at very low doses, its antihistamine activity dominates its pharmacology. This led to the development of a low-dose formulation, Silenor, approved for insomnia at doses of just 3 to 6 milligrams every night. In other words, the same molecule can function either as a full antidepressant or as a sleep medication, depending on the dose. The side effect profile of tricyclic antidepressants is largely explained by their receptor activity. Anticholinergic effects can lead to dry mouth, constipation, blurred vision, and urinary retention. Antihistamine effects contribute to sedation and weight gain. Alpha-1 adrenergic blockade can produce orthostatic hypotension and dizziness. Another important clinical concern with TCAs is cardiac toxicity. These medications can block cardiac sodium channels, which may lead to conduction abnormalities and dangerous arrhythmias in overdose. Because of this risk, clinicians prescribe TCAs cautiously, particularly in patients with cardiovascular disease. Despite these limitations, TCAs remain valuable medications in modern psychiatry. In addition to depression, they are used for neuropathic pain, migraine prevention, fibromyalgia, and certain sleep disorders. In treatment-resistant depression, they continue to demonstrate robust antidepressant efficacy. Today, while newer antidepressants dominate routine prescribing, TCAs remain an important part of psychopharmacology. Their continued use reminds us that older medications, when used thoughtfully and monitored carefully, can still provide powerful clinical benefits. Thank you for watching. If you find this episode helpful, please share it with colleagues across disciplines. See you in our next episode on SSRIs. Bye.